this is a 18-year-old who has practice developed in his late childhood. Symptoms of exercise intolerance, some shortness of breath, tachycardia, chest pain. Most of his defect is very low. You can see down here into the abdomen. Cuts don't go too deep, but you can see here a little bit higher. Color index is right at 4. Should be a relatively simple repair. The young gentleman. We'll show you all the basic techniques for nice pectus repair.
Yeah.
But even though most of the defects low, as we go up, he still has some slight defect kind of all up the majority of the sternum there. So we'll end up using three bars on him to make him look good and get him completely corrected.
So right now I'm just marking the end of sternum where xiphoid is. Just marking the end of sternum where xiphoid is. You don't want to go down too far below that point, but we have to fix the defect, which is here. Its primary defect is in this area.
Thanks, Jesse.
Yep. So this being his primary defect here, you're going to have to try and get bars right here in this area. So you have to go in his inner spaces. So we mark off the inner spaces where we think we're going to be putting bars, probably 3 bars on him today. And then you want to mark midline for our 4 sternal elevation, which we'll do. So then we'll mark midline because you don't want to put any incisions that aren't where you want them. So he's pretty symmetric, so you can follow just midline linea alba up to manubrial notch and get your midline. These are where the bars will probably go. And then in a second, I'll go on the other side and we can show you the markings for incisions. Okay. There's our midline mark. And I'm going to move over to the head of the bed here in a second. Okay. And again, we'll mark our lower marks for our intercostal spaces. So this is where we'll put the bars. That way we can correlate one side to the other. So this is a rib right here that we'll probably go in on. That'll be our incision from here to here.
So how do you generally plan your incision position? What's your general?
It's primarily with 2 finger breadths down from his areola. You can also kind of go off axillary line at the base of your incision, because this is where your bars are really going to be sitting at the lowest point laterally. And then try and make them symmetric so they're the same on either side.
So just a couple of things about planning incisions. We always do our incisions at an angle. You want to do 1 incision to get as many bars as you need in here. By putting the incisions at an angle, it allows you to reach the lowest bar, because you can always extend the incision a little bit to get lower. And you can extend a little bit this way to get higher, whichever way you need to go. And this, boy, we're pretty sure we're going to do 3 bars here. So this incision is straddled between these 3 bar locations. If his defect was a little lower, we could potentially go a little bit lower with this incision. If we were going a little higher with bars, we could go up a little higher. So we could go, one rib space higher, and angle a little bit further back here. Or you could go lower, go a little bit lower this way. But it's almost always ends up that this is about the right location for this, right here. And obviously you want to be as close to even as possible. It's surprising how many patients are actually not symmetric, and you end up, you're trying to measure and you're like, their nipples are off, and you're like, okay. And so visually you want to try and make it look as even as possible. Sometimes with the severe asymmetry, you visually make it look even, and then when you fix their asymmetry, they come across as looking very uneven, and I'll actually try to cut the skin to make it look more even at the end of the case. And so it can be very hard. Same thing with marking the center. Sometimes the center of these guys is so far off, and using a tape measure to measure the nipple of where the center of the skin is, it will, try to make your clamp marks there versus, following, because it can be very different in some of these patients, and it's always hard. The same thing with the carinatum. Sometimes it's hard to figure out where the actual center of these patients is.
The camera ports. Is that?
So the camera port, we're going to start here, and then we'll put the port after we get the CO2 in, because it's going to move the diaphragm way down low. We want to get as low as possible, and so we'll do that after we put CO2 inside.
They've got the CO2 settings at 11 millimeters of mercury at 11 meters a minute, done routinely, and Jess tells me that they go up to 14 if needed.
So these are our Walter retractor holders, robotic holders. So this one will hold the camera, and you want it far enough away from where you're working that it's not impeding where you're working. So this one will be right here about for where our camera would be, so it will hold the camera so we can move it around inside the patient. This one will hold a retractor, and it will primarily just hold up here so that we can work independently, tying in the bars and stabilizing everything. So we're going to put some Iovan, which is an iodine impregnated barrier. So this is Iovan, iodine impregnated covering to help with resident flora. Want to make sure you don't stretch it on the patient because they can get burnt and from the just from the adhesive on it. Scissor. So I want to take extra caution when draping Walters.
In the pre-op, patients are started on gabapentin ahead of time, and so we do a taper on them. We want them on 300 milligrams 3 times a day by the time they get to surgery. So we'll start them on 100 milligrams. They'll do that 3 times a day, and then they'll increase that weekly. They'll go to 200 milligrams, and then they'll go to 300 milligrams. So that they'll come to surgery on the 300 milligrams. The morning of surgery, we give them 600 milligrams of gabapentin. They get 1,000 milligrams of Tylenol. It's just 400 milligrams of Celebrex, and then we give them dexamethasone IV, 8 milligrams. So that's like their morning breakfast. Their yummy cocktail for breakfast. Now, intra-op, We try to minimize things that are going to cause nausea, vomiting. So we try to not do gas. We try to do the propofol. Don't see propofol in our blood range. So we use propofol, and then they'll get some Toradol at the end. We're going to do cryo for pain control, so usually they won't do any narcotics. So we do methadone. And so for someone his size, he'll get 5 to 10 of methadone. A larger patient maybe will get 10 to 15 of methadone. And they will give that at the beginning of the case before we even start to kind of download and block all the pain receptors. I'll also be doing an intercostal block with 0.25% Marcaine and some dexamethasone also. They'll mix that together. It helps with the inflammation of the nerves, because when they do the cryo, it's hard to say, but there's some evidence that maybe it takes a little bit of time for the cryo to kick in, and there may be a little bit of lag time. Initially, we were doing some on-cue subcutaneous things, but that takes a lot of extra time and they're expensive. And so now we just do a block, and it seems to be doing just as well. But there's definitely a little bit of pain that first 6 hours or so that before the cryo totally kicks in. So we usually do that block. And whether you want to do it at the very beginning of the case, you were doing it initially at the very beginning, but then it took extra time. So now we just do it while we're doing the cryo. I haven't seen that it made that much of a difference, but I think we can choose whether you want to do it ahead of time and get the maximal effect, or whether you want to do it right when you're doing the cryo. Basically, we're just going through the incision, tunneling down to your muscle layer. Some people will go just through muscle. I make a pocket and go completely under muscle for my bars. I'll try to follow the muscle fiber direction and just kind of separate through. Once you get to your ribs, you can kind of use your pickup and you can pull the muscle out, kind of get that filmy layer. Yeah, inside. Nice strong muscle. My old ladies, they're easy. You just slide your finger in it.
Yeah. Bodybuilders.
Sometimes you can use the end of this pickup too. Save your finger a little bit. Jesse's a lot stronger than I am.
Yeah, I think Jesse's
He's got
beating
stronger
you.
fingers. Yeah, he always beats me.
Yeah.
I waited a little while too. I didn't want to interrupt the video.
Make sure you're all the way underneath that muscle. You stay in the right plane. Sometimes on the really deep defects, it's difficult because they dive down so deep you can't actually get your finger down there. It's so far away. So I'll do partial dissection, and then we'll get a bar in and I'll finish it because I can't reach it. It's just so far away. So I'll initiate through this pocket here. Turn our gas on. CO2 on. So we usually start at 11:11. Gas is on. People can go at whichever there they want. Sometimes it's too high and we have to turn it down, the pressure drops, but most of the time they tolerate it okay, and you end up with enough holes in that you start losing CO2, so you start off pretty high. It's a little cold. Got more water on. Now, as far as location, if you go too far back, you're not going to be in your cryo field. But you want to try to get, you figure you're going to be time here, so you don't want to go too close to it or you're not going to be able to see it. So right about where Jesse is, that's too far, that's, just about right, the Goldilocks thing. So I'm going to go right about there. Gas down here. Can you take a photo for me? And another.
Our forced sternal elevation. Lift the sternum up so that we can dissect underneath safely. We use a Lewin bone clamp. So when doing this, you want to think about where your bars are going to go and put your holes for your Lewin bone clamp somewhere where you can make those holes useful for stabilizing the bar later. Right.
That's totally unmodified, that Lewin bone clamp. That's just, you haven't bent it or changed it in any way?
I did maybe straighten out the pillars a little bit so that it doesn't come in like this and overlap, but more like this and come together.
Okay, yeah.
So I try to hook the sternum and get through the top plate, top cortex of the sternum. Not going through the entire sternum, just the top cortex. And good solid bone in the sternum there. We use a rule track to lift up on the sternum. I try and put this as close to the head of the bed as possible. To stay,
As far up as possible.
to stay out of the way. So above the shoulder, so that you have room to work in this area.
The secret is he pushed that in with his thumb,
Okay, yeah.
and then he rocked the other end. So he's rocking those in. Because if you just close it, it just skives off the top.
Yeah, that's good.
So we're going to lift his sternum up. You want to get another blood pressure? This is where we fall. Thank you.
So it can be, it's not uncommon that you can get a little bit of Valsalva and low pressure. Sometimes you'll see for whatever reason, their heart rate will drop down.
Yeah.
So we always try to warn anesthesia so it doesn't take them unaware when the heart rate drops down to 40 and blood pressure drops.
You never use arterial lines or central lines? You
Yep.
don't need any
We
of that,
used to
do you?
use
Or
We used to use an
catheters?
art line, but we don't anymore, unless it's a really difficult case where we're concerned. But we do always on the bar removals, but not the insertions. But it's just the heart, when the heart's really compressed, it's empty, and then you lift that up, and you basically take them to CVP of negative something, and they need volume, and it takes a while to catch up. So I usually start this with an endo-Kittner. Sometimes the pericardium can really be stuck up, and it's easy enough to get into it. So I'll get started with the endo-Kittner and just try to get through this fat and tease it down. You can use any tool you want. I feel like I can do no harm with an endo-Kittner. As long as they have pericardium, it turns out you can do a lot of harm if you don't have a pericardium. And I have dissected into the heart before on a redo case that didn't have pericardium. But once you get across, you can see along on the other side, you still got a little pleural. You can just pop through that and get CO2 on that side. Then Jesse will come from his side, and he's going to hold the pericardium down in the heart. And then I switch to cautery so that all of these vessels are super annoying and bleed.
Yeah, as you brush them, they just bleed the whole time.
Yeah.
Don't they?
So then I'll use cautery. I'll just take the rest of this down with electric cautery.
And obviously the elevation massively helps, isn't it?
Oh, yeah.
But, isn't it? I mean, it's like mandatory, isn't it, really, to use elevation?
Yeah, I mean, I honestly, every once in a while I have a patient that's completely cosmetic, and they'll be like, I don't want you to put the clamp because I don't want the scar. And I'll tell them, well, then you need to go somewhere else to have your surgery done. Because I honestly don't think that this is a safe procedure if I can't see. And I think the elevation makes the difference between this being a safe procedure and not.
Yeah.
And they can go somewhere else. Because I don't want to ever be responsible for something happening to a patient. I personally would have a hard time living with myself. The critical part of any case, you don't do what you can't see. Don't never guess.
I'm going to go around on one side.
And you like to open this fully up. It doesn't take long, does it? To
No.
open this up.
No,
It's
it
just
takes just
a couple of minutes.
a minute or so. And a lot of times when you lift them, these spaces will shift. And sometimes you'll be like, oh, maybe I don't actually need a bar down there. Maybe I actually have to go higher. And you can realize that maybe you actually only need 2 bars, or maybe you need a bar higher than you marked. And because my interspace now is moved a little lower, it's way down here.
Yeah, it's quite a bit lower.
And
than
then this one is
xiphisternum,
here.
isn't it?
And this one's moved up higher, right?
Yep.
So now this space is here. So
Dissect.
a couple of things about entry. You can see your internal mammary artery there, and then you can see where the turn of the ribs is, where it curves.
Yep.
You always have to be medial to that turn, because if you're coming out here, you're not going to get enough elevation. So you have to be medial. I like to be, at least 1 centimeter or 2 lateral to the mammary. So coming in here.
Yeah, a lot of surgeons go more lateral than that, don't
Yeah,
they?
if you do, you're not lifting the chest because you're not getting enough push in the center.
So I'm feeling the turn of the rib and going just medial of that on my side as well.
So you can see his knuckles really well from this end, that he's going, way medial to those knuckles. Turn him.
You want to do it down low?
Yeah.
You want to turn it?
Is that a fiber wire?
Yep.
Connected?
Put a fiber wire over it?
Yeah, so put a fiber wire in the end. We're going to use that as our guide. Now, in someone his age and as small as he is, you could easily get by without reinforcing this. It didn't strip out. If you look at the hole, it's nice. It's a nice solid hole. There's not a huge amount of pressure up there because all we're really doing is putting a little bit of curve to his upper chest where he's flat. We're not pushing out a big defect. So technically you could get by without putting a hammock stitch. But for the purposes of this, since we're trying to demonstrate hammock, we're gonna do one. And it's not gonna hurt because that way we 100% know that this bar is not gonna move. So the premise of the hammock stitch is that you have your 2 intercostal spaces. Your bar is going to be sitting here. if this muscle rips out, your bar is going to fall through. So the point of the hammock stitch is we're just wrapping the fiber wire around that. Then we're putting the bar in, and the bar is going to sit on the hammock so the bar can't fall through.
Yeah.
So I like to use a big right angle or big my clamp. You can use a smaller clamp, but to me it's easier to get the thing to pass. And we're basically going above, the rib above. The rib below. And you want to go fairly close to where your heart entrance and exit is.
That's right on it there.
And then you're going to come down and skip the space of, at least a centimeter. And on the adults, where you worry about them fracturing is that transition point between the cartilage and the rib. So I always straddle that section because it helps buttress. Now Jesse is going to do the same on his side. He's going to come over here. Again, there's your transition point, and he's going above, and he'll go below. Sorry. Doesn't need to be super tight.
You like it super tight? It doesn't need it, doesn't
Nope.
it? It's just
Nope.
literally a hammock.
Yep. No, it doesn't need to be super tight.
And just a note on fiber wire versus any other suture and things, it's just perfect because it's non-absorbable.
Yep.
Nice and thick, doesn't break.
It doesn't break easily. The big disadvantage of it is it's slippery, so you have to tie a bunch of knots.
Yeah.
So on these hammock ties, we'll do, like 14, 15 throws, and then I'll usually do like a surgeon's knot in the middle.
Okay.
So we gotta make sure they're pushed all the way down and secure. They don't work if they don't stay tied.
And obviously it's not going to have any problems on removal, is it? Because it's out the way. The bar's over
Yeah,
it.
and if you want to take them out, you can dissect up there and cut them. You can feel them with your finger when you get up that far.
So normally I'd measure on a CT scan and I'd know what size bar I wanted.
Okay.
Kind of guessing to start off with, but so this bar is a 13 and a half and it would work really well probably where we're at. It's a little bit smaller up here.
And in terms of the sizing, you just
Yeah.
want the ends to your incisions.
Yeah, so you don't want to go. There's no added benefit to coming this far back. All you do is have a lot of swing to the bar. If you're putting ties, you potentially could get the long thoracic. If you're tying way back here. And if you come up here, you're too short. You're worried that the bar is not tied in enough spot, or you can fall through the interspaces. So somewhere between here and here is probably an okay length. There's
And your bars come pre-bent.
These are the
Seated.
Pectus Blue. They come pre-bent, kind of like a generic bend. So I always bring it up to the patient. I sort of figure out where I need to bend it to fit each patient and each bar. Because as you change the shape of their chest coming down, the shape of the bar might change a little bit as well, because they tend to widen out. So I'm going to use this 13.5 up here, probably use the same size on the next area, and maybe a 14 down below that. because he's going to widen out some when we fix the pectus. It goes from here to here, and they get wider.
And just a note.
So his bar is going to come out from underneath the sternum around this area here. So just lateral to that, we want to start our bend. And then somewhere around his nipple line, and then we're going to start bending around the side of his chest wall. Somewhere around here, and then again around there. So you have, let's say, what is this, like a 10.5. So you would mark 4 and 8 centimeters on your bar, on your flat stainless steel bar. This is a template, obviously it's going to be different. Then you mark both sides. I'm marking the underside of it, because that's the side you're going to see when you're bending it. So then we would take our bender and we do partial bend here, and we do 3 bends. Jesus, it's been so long. 3 bends in between this, 2 and 3, right? And then on the end over here, you do, these are full bends, 1 and 2. And of course, on a stainless steel bar, you're going to see it's going to be a little bit different because the bar's thicker and has more memory, so it'll come back a little bit more. Then you reproduce that on the other side. 1, 2, 3, full bend, and then there's your bar. And that's essentially, it's very reproducible because you have marks and measurements. And it seems to fit on everyone the same way. You might have to do a small adjustment here or there. A lot of the times it's bent in just a little too far on the end here, and you have to straighten that out. But a lot of times the patient will bend it down, it'll come out. But
And then just maybe a little one in the middle, or just...
so usually if there was something in the middle that I wanted to do, the stainless steel bars are so easy to bend, I would just bend it with my hands.
So that's a nice reproducible
And then,
way
yeah,
to-
it's just, then you can shape it, you customize it to any patient, and that is a very generalized basic bend that you can reproduce on every patient. Much better than the bend that they give you from Biomet on the titanium bars. But their thought for these titanium bars is you shouldn't need to bend them a whole lot, and that way you're not causing micro fractures in the finish of the titanium. So, but the stainless steel bars, this was before we started using titanium. This is how we bent all the bars, same algorithm, 4 and 8 centimeters. You start with partial bends until you get to the 4 centimeter mark, and then you put 2 full bends there. So you would, like a partial bend here, partial bend there, and partial bend there, full bend here, and a full bend there,
That's it done.
and you're done.
Okay, great. Fabulous. Yeah, well, that's well.
So I put those marks on the bar, and now we're going to bend it. And these are just partial bends. This is the Biomet table bender that they should provide with you when you get your pectus bars. And it's just a partial bend, so it's just like a half or quarter bend. And I put 3 to 4 of these in here on these titanium pre-bent bars so that it will curve more around the patient's chest. And again, I'll do it on the other side. Then you want to check for symmetry. So you put it up against the straight edge and just make sure it's the same on both sides at its highest point. On that point it was 7.2 on each side. So it's pretty symmetric.
The central curvature, you don't do too much of a curve.
So on this guy here, with these titanium bars being pre-bent the way they are, if he had a larger defect or it was a female, we'd probably bend it in just a touch, but not very often. We usually pretty much leave the center alone. Now, if it pushes them up too much because it's titanium and a stronger bar, we can always readjust that. Very good. All right.
Nice.
So now you can see after bending the bar, it's tight on his skin, pushing in a little bit, and that will compensate for the amount of skin and muscle that he has on, being inside the patient instead of outside. He will also widen out just a touch, so he'll by the end, this bar will probably fit almost perfect by then.
So now we're going to take our Firewire and tie it to the end of this bar. I'm putting my finger in, so I'm feeling where this hammock is. And I want to make sure I'm going in on top of it. And it's very easy to tie your string into the hammock. So you have to make sure when you're doing the hammock that you're putting your string back and forth and not incorporating it into your hammock, which when you first start doing it, you tend to do consistently. And if you think you have, it's really easy. Just pull your string back and put a right angle in and just replace your guide string. And then when you do this, the reason I'm doing this short is when you put these flippers on, it tends to mess up your fiber wire. And so then you're tying right where the weak spot is. So I do that so that I'm tying then on a area that's not weakened. Okay, 1, 2, 3. Next interspace. Yeah. All right, so now we're going to come down, dissector. Again, better.
So now she can.
Medial. Cross. Again, never do anything you can't see. Feel. Retrieve. We have the table down. Stretch, but. So for the adults, this kid's really young, 18, so his cartilage is flexible. But for the adults, we'll do that. And a lot of times you can crack their cartilage here and get them to reduce down and kind of reset their rib flare.
Reduce the flare, yeah.
So we'll do that on all the adults.
Yeah.
He's just flexible, so nothing happens. He just bounces. Now again, we'll do the hammock on this. This part has more pressure, so this one's going to be a little bit harder because now you have a bar in the way. So you have to go over this rib, but underneath your bar, because you don't want to tie your other bar into your hammock, or it doesn't do its job. So you're basically sliding in between that bar and around the rib.
Throwing the stitch at Jessie.
And Jessie retrieves. So Jessie's self-sufficient. I'm needy. I don't like that the Bakey grasper because you can push it too far into the chest, into things. He likes it. He doesn't have to wait on me to retrieve for him. But it's very easy to poke into things if you push too hard. So I try to so I'm a little far back on this stitch. So I'm going to take this out and I'm going to redo it.
Yeah, just beyond the peak of the ridge, isn't it?
Yep.
Yeah.
Huh? Yep. Take that back. It would probably work, but it's not ideal. It's not. And sometimes on these, it's a little hard because the bar is not letting you go where you want to go. So this would be a few more medial. It's probably too medial. That's better. And then I can go on one side or the other of that string. I'll probably go on the other side just so I can straddle it. Since I already went in the first time, I don't want it to strip through. This time I'm going to come here. So Jesse's using the right angle, but normally he uses this DeBakey to pass.
This is for you guys.
Didn't like having to wait for me to pass it. You can see really well these knuckles
Yeah, it's
and
right on
the transition, so it's really nice.
exactly
Example.
where the bar's going to go, isn't it? And that's crossing the transition
Yeah.
where the fracture's possible.
Yeah. So on an older patient, it'd be really, oh, I lost my turn. And so this one kind of stripped. See how it kind of ripped and stripped? And so it's probably fine, but say this is an older person and you got a partial fracture, it wouldn't be fine. So in a case like that, we would go a third time around. So just as an example. We would take it around a third time, so to make sure that that area is, supported.
Yeah, it's super easy to do that, isn't it?
Yeah,
20
depending
seconds.
on where the fracture is, obviously you don't want to tie where the fracture is, but making sure you're well above and below and both sides of that fracture are supported, so that when you tie it, it's secured in.
Yeah. That's nice.
And I will occasionally, we'll get some of these guys that are like, 250, 300 pounds or, 110, 20 kilos or so, that are massive. And sometimes we'll go 3 times around because we're just like, I don't know if my Firewire is going to be strong enough to support this guy and his bars. So we'll just automatically go 3 times around to give it just a little bit extra because we're a little worried about the weight that's on the bar. But the same idea. Especially if they're 40, 50 years old, great big guy.
Yeah, these Hammock sutures are great, aren't they? It's easy to put in, give you just 100% reassurance. Getting lifted. So you've actually always put titanium bars in?
No, I mean, we used to could only get titanium if we special ordered them, and they had to come from the company pre-bent and stuff. Now we have our own set of titanium, which you can only get these stabilizers in titanium, so I think that's far superior. So we put titanium in a large proportion of patients.
Again, the bar is going to come out around here, and we're going to start curving. There comes out around here. Start curving around there. We'll get probably 4 bends on this bar for him. Just partial bends from our first mark around to the end.
There's a young kid that had like really pointy, eyes.
4. So here's a bar before and after. Then we'll take it up to the patient and see if we need to modify it anymore before we put it in. And again, you can see how it's nice and tight on the skin.
Yeah.
So that way you know it's going to fit underneath the muscle that we went through onto the sides of the rib cage, and should fit really well.
fiber wire, please. So we put these fiber wires in just because I'm lazy and it's easier to put it in here than
much
it
easier
is
now,
to
yeah.
try to do it once it's flipped.
Yeah, totally.
Saves a step, but you don't have to do that. It does make it a little harder to get the flippers on, for sure. All right, so now the big question is, on this guy, do you put another bar below or not? And he looks pretty decent. But what my concern is, and that I learned through all these years, is what you're looking at right here is that rib there. And my bar is here, and you still have this down here. And when they come back in 3 years, this is caved in underneath that lower bar. And they have this scalloping underneath there. And I'm like, why didn't I put a bar down there? Because he looks perfect right now, but that's not what he'll look like in 3 years.
Okay.
And then you get a CT scan, and this stuff is caved in, and he's got a little bit of compression from that dumb rib that's kind of fallen in. And it's tied up, so maybe it won't come, but if I put a bar in, this is gonna stay up, it's gonna look just like that, and we're all gonna be happier. And so, experience has taught me that I will not be happy with my repair if I don't put a bar down here.
Yeah.
And so the reason my number of 3-bar repairs has increased significantly is this very reason.
Because you see your patients.
Because I see my patients in follow-up, and I recognize that I should have done this in more people than I wasn't happy with. And that's not true for everybody, but you know, some repairs, it's just, that's kind of how it was. But you know,
And if it's slightly
putting
under this-
another bar wouldn't have changed that down lower. That's just how their chest wall is. But in some of these patients, you know, I wish I would have put a bar down lower. And it's going to be an extremely flat bar because it's not that I need to lift him here, I need to lift him out lateral.
Okay, yeah.
Because it's these lower costal cartilages out lateral that are a little bit more of the problem. And so,
Yeah, and it's even below the xiphisternum a little bit. But that's
yep,
fine.
it is.
It's
It's
yeah.
below the sternum.
It's right at the end of xiphoid right here that I marked earlier, which is why I marked it.
So the biggest problem with this bar is stabilizing it, because these bars move because there's nothing holding them in the center, so you can't really secure them midline. And that's where these that's where the lateral, you know, bridges and the medial stabilizers have made a difference. And I think that I probably, you know, didn't have that as an option before, so that's another reason we weren't putting bars down so low, is we just couldn't figure out how to stabilize them so they were moving when we put them down there. It's a little bit more lateral on this side, so that I'm pushing out a little bit more lateral over here. 8, back here. So it's gonna be a little bit harder to see. So low. Should listen to Jesse on the first one. Macrame. Not everybody can macrame in the chest.
Yeah, that's good enough.
Cut that little piece of.
Tissue.
Lily, can I get another pack of last, please?
That's a little bit flatter in the middle, isn't it?
Yep.
Yeah, nice and flat.
Otherwise, it'll push his xiphoid out.
Yeah, and that little.
So he
yeah,
actually
really straight.
actually
Oh, you
bent,
did
bent,
it.
it, bent it down just a
Tiny,
little bit.
like
Okay.
a millimeter. Two.
But again, we don't want to push up at all in the middle.
Yeah, that's, as you said, it's getting the sides out. Just going to use this on that lower one.
So this. Push it as far over as I can reach. This incision. Just lock it. That's it.
Yeah, that's so
It's
easy
so
to
much
use
nice,
that.
I know.
Oh, God.
And then what
I don't have this Biomet blue set. I've only got the standard, and the stabiliser plates are awful compared
Yeah.
to those.
No, I
Those
know.
are beautiful, aren't they?
I know, they're nice.
You can't even, lovely stabiliser plate, just slips straight on.
But you know, you
Tight
just
and
you
done.
just need to kind of, like you said, past that, you know, anterior axillary line.
Yeah, and it's so quick and easy to put that one on, isn't it? It's really nice.
So then I take the tie through the end of this guy, and I go underneath the bar above it. And I create my own bridge.
Yep, never even move.
So I just tie these two. That's something weird on that. I just tie that stabilizer to the bar above. Just lock those two together. It's added security.
That is calm.
So we put lots of ties. I don't know what the right number of ties are.
7.
We probably could do a lot. Uh-oh, we gotta get rid of this camera. We probably could do a lot less ties, but
Sleep better at night.
yeah, we just never cut back our ties, even though, like we did the medial stabilizer, we probably could do no ties on the bottom bar, but or just the distal one. You know, this is basically just
Yeah, the lateral suture that's
the lateral suture.
in the eyelet of each one. Yeah. Each
mean,
one goes
you're-
round the rib. Yeah.
Right, I mean, you have a medial stabilizer and then you have your lateral. Jazz, you mind holding the retractor?
Yeah. Emily, do you open one or two?
Again, this makes-
Technically, this should be all you need, but I still put one on every single rib that crosses because I haven't gotten comfortable enough that I don't.
Thank you.
but-
You just like perfect.
Yeah, I don't, just me, but.
The only way you're gonna find out is to not do it.
I know, not do it and
And then
then,
if it doesn't work, someone has to suffer through that.
Yeah, totally.
right,
yeah.
so. I've been afraid to not do it. But I only put 12 knots in these.
Maverick.
Just basically anywhere that the ribbon bar cross, put a tie there.
Jesse has the hardest side for doing this, and you have the easy side.
I know.
Right, yeah. So he's been pretty much by
He's going
magic.
backwards.
Yeah.
He uses that DeBakey grasper. He drops them on top of the heart.
Yeah.
Goes up and drops them on the heart. This is side by braille.
Yeah. I guess a few notes on bar removal, just while we're here. You always prep the groins,
Yep.
always open both sides, get them straight,
Yep.
direct tug out, and then you connect a fibre wire to one end, just so about the sort of
Yeah, you
packing
can
the
or
track.
you can't. So I always have a PA and lateral X-ray and look at
Yeah.
that. And if it's somebody else's bar, I don't know what's happened and if there were any trouble. So when bars go in easily without any issues, it's very rare you have problems, but it's possible. If you have really good visualization of the track, I don't necessarily tie a fiber wire to the end because I can easily pack that track. If it's a big guy with a lot
If
of,
you pull it out, how do you pack the track? You just
you can see it. You can see the track, and you can
It's a nice big
easily
hole. You
you
just-
can easily shove
Okay.
use a DeBakey grasper
yeah,
and
just to block
a
the hole.
DeBakey pickup and just shove something in there.
Yeah.
You can get your finger in the track easily.
Okay.
But if it's a big guy, if it's a high bar, then tie something on it because you lose visualization of that track and it
Then
can
you
be
can
hard.
pull something
It
through.
can be hard to get it again. It's almost always your internal mammary that's bleeding if it's a heavy bleed.
Okay.
And you know where your mammaries are, and a lot of times
She's gonna
if
be
you-
moving in a second.
If you just push here, you can get partial control. It may keep bleeding some, but if you have someone just push down on the track about where that mammary is, it'll slow it down. Yeah, the first time it happened, it's like this sheer panic
Yeah.
because you're just
Yeah,
like, oh my
it's
God,
gushing,
this
yeah.
patient's gonna die.
Yeah.
And so if you
Did you actually had to go and tie off a mammary artery, or so you've always been able to control it with pressing and tamponading and packing?
Yeah, we had
because everything's
one-
going to be stuck, isn't it? That's the thing.
Yeah, we had one that we got crazy and overpacked the track. So we broke the kind of fibrotic sheath on the track, and we started getting some bleeding in the chest. So we thought we were going to end up having to tie the mammary off, and we got the camera out and everything. But by the time we got the camera set up and got in the chest, it stopped bleeding. But
So you were going to do it in the chest.
yeah,
right
we were going
chest
to try
approach.
to clip it off, or go through the chest with like kind of how we'll show you when we tie the bar in the middle.
Okay, all right,
We were
yeah,
going to put the
get
ties
round
that way,
Okay. Yeah.
where I could see it with the camera. We were hoping there weren't too many adhesions in the chest that we could do it that way.
Post-op antibiotics. Do you give them a prolonged course or not?
No,
really?
we'll do IV cephalosporin as long as they have a chest tube in. So we'll leave a chest tube where our
Chemical.
camera is, right here. And it's usually overnight, but in some of the bigger adults that are muscular, they'll be a little more bloody, and so they'll end up staying an extra day just because of the chest tube. It's a little stiffer, doesn't lose its shape as quickly, and it's a little faster. So I do three. I do 3 through 9 for everybody,
3 to 9. Okay.
regardless of where the bars are.
Yeah.
It's just kind of our standard.
There's a company somebody says just do 5 on either side, but
Yeah.
there's no reason for that, is there really? Yeah.
Yeah, I do 3.
And they say never do the second, don't they? Yeah.
And there's this big debate on where you put the probe, and honestly, I don't know the right answer.
Yeah, so after seeing your videos, I've gone a bit more laterally, and I guess the axon just, it retracts fully, doesn't it? Right back to the nerve, doesn't it? So to me, it seems that if you've destroyed it, so it's going to go back to its nerve, it's going to retract all the way back, isn't it?
Right.
So I haven't found any difference going a bit more lateral at all.
Yeah, I mean, I
found
used
that-
to try to go medial, and then Jesse was going always lateral on his side because
Yeah,
you know he
'cause you're
can't
coming
get medial,
across, yeah.
and his side was never any different than mine. So then I was like, don't know that it matters.
Yeah, and I was prodding and poking the lung to try and get really medial, and then I was worrying that was causing air leak and things like that. So I think not touching the lung really helps.
Right.
You don't want to get an air leak, that's a real pain. You don't want a prolonged drain. I've never managed to be able to do cryo and do something else at the same time. I wish, like tying some hammocks or doing something else.
Yeah, it's really hard because it's in your way.
Yeah, it's totally in your way, isn't it?
And so usually Jesse will do his drilling and stuff while I'm doing the cryo.
I suppose that's
Yeah, we had a potty break. But it's really important on the cryo, which I didn't know, because no one had told me, is not to pull it off before it's unfrozen. Because I was pulling it off early, but apparently that can permanently damage the nerve sheath.
So you're just using 90 seconds.
Yeah.
So this is the.
So it's 90
is that
seconds.
10 mil? Is this the 10 mil probe? Is it? Or-
So the new probe is only 90 seconds.
Yeah. Oh right.
So
wow.
it's really nice. And it doesn't have the turnover time in
Yeah,
between.
'cause it
So
took
it's
forever. Mine.
Yeah, it's
Mine
significantly
literally
faster.
Half a minute to bloody cool
Yep.
down. That's brilliant.
It uses
yeah.
much less gas. It's much quicker.
So these are the two incisions where the clamp was for the forced sternal elevation. And now we're going to tie our bars to the sternum so they can't rotate downward. So I preset this drill guide to stop at a certain depth so that I can't cause any harm to the patient, like putting the drill through their heart. So you set this on the sternum. And drill through the sternum. There's your drill. It's a Houston suture passer. Goes in. I'll take the new use. Perfect, thank you. Say I give you a compliment. Perfect, thank you. Do the Houston suture passer. Back out. Dawn's gonna reload her cryo
So in the interest of time, we should try to do these things at the same.
congruently.
So we don't waste any time.
90-second cryo probe.
This here. Will contaminate.
Drill
I'm not
today.
shitting.
Houston suture passer.
Coming.
Did that the hard way. Hemostat, Joss? Hemostat? Thank you. Drill gag.
So we have two sutures
Drill
now
gag.
that he's taken around the metal bar. And make us look like superstars.
So this will also catch their xiphoid. Yep. I don't like using this right angle, because it makes the hole bigger. Yeah, the hole is just almost double in size.
There we go.
Make sure it's long enough. Can't see the camera.
It is. Another hemostat? So now it's around both those. Want me to- So now it's around both those. Can't see. Okay, now you can go back to cryo and I will do the upper one. So while she's doing cryo in there, I'll do the upper one.
So much quicker, isn't it?
It's almost not enough time to do anything in between.
Yeah, it's so much quicker.
Pretty long. This one?
Can we let family know we did 3 bars? You did, thank you. Don't have much pressure on it. For demonstration's sake.
Do you see much upper abdominal bulging a bit with the knife ones? If it's any more?
Not with 9.
You go
Yeah.
too low.
If you go below 9, absolutely. But usually if you keep it to 9, it won't. You know, every once in a while you have a patient that complains a little bit. They feel like it's bulging.
Occasionally you get the odd numb bits when they come back for bar removal, but usually not that bothered, are they?
You get a lot of numbness. I will say we do get a lot of numbness with the 3 bars, but I make sure when I see them pre-op that I extensively talk about that. Because, you know, first of all, they blame the cryo, and I want to make sure that the cryo doesn't get blamed. Because it's not the cryo, yeah. It's the surgery and the dissection planes and the bars interrupting, the ability of the nerves to regenerate. So I make that really clear to them. And I tell them that the worst thing in the world, especially women, is you maybe could lose sensation to your nipples, then don't do the surgery. And so they're well aware of that. You see, or you're good? Like, it's almost too fast. You don't have time to do anything. Let's see. There's my chest tube, which is that. So that should be good. That should be the lowest stitch, I think.
I always use count by about the 4th freeze.
That's my lowest stitch. That should be 9. Okay.
Did you say how much dexamethasone you use?
10.
10.
10 milligrams, 1 ml. So that lower stitch that we put in, I try and catch the xiphoid in it, so it pulls it down. Because throughout time, sometimes they'll kick up when sitting on top of the bar. That's why I had her push down on there. And if you're really trying to be nice to, it's usually on women. If you go a little further past the xiphoid, like do a separate stitch like around the bar itself, and go down a little past the xiphoid, because they get that bulge from the xiphoid, then you push that down. You can grab some of their like fascia, linea alba, and you can pull that up, and it creates a nice line. And the women really seem to like that. It almost gives them abdominal muscles. Defines them.
Is he taking them? Or not taking them over there? Okay. I need that so this back in a second. Oops, that's it.
So I out of habit still put this lap in here to protect the incision from the probe.
Because the old probes.
So I just put a little 16 French tube. You probably do like a, like a Blake drain or something soft. Just do a 16. Probably don't have to show us closing.
Well, we need the final view of the beautiful chest.
We need to close, but I was
That's
telling
what-
Randy he doesn't need to tape us closing. Pretty sure you don't want to. Nobody wants to see us closing.
I can always do a little tiny, super sped up bit. Patients like the closing bit actually. They're fascinated.
Guess he does a much prettier closure than I do.
Yeah, so here's the binder.
Excellent.
And that's a piece of foam. And that'll be on for 24 hours or so, and you'll go home with that.
Put it nice and tight because it puts pressure on the sides and the front. Keep things from swelling up and going black and blue.
So this is the 4-chamber view at baseline.
Yeah, so that's before
Yeah,
the
so
operation.
here is the pectus compressing the mid to distal RV free wall.
Yeah.
A lot of the time we will have basal RV compression and this thing would be very narrow, or the RVOT compression. So there are different, places where you see the compression, irrespective of what you see visually.
Yep.
So anyway, so the interesting thing here is that the LV doesn't look that good. And that's typically what we see with this patient. Their EFs are like between 46 to 51. They're not very vigorous, yes.
Wow.
And so what we do is we do LVEF on them. It's like an odd looking ventricle and the images are difficult. So here is the 3D acquisition we did. And I now want to show you the same view after the repair. And you will see the difference. Okay, so here is the 4-chamber view now. And I don't know whether you can appreciate a slight reduction in the LV size. And even though the LV contractility is not as brisk, it's still probably 53% or so. But, the morphology has changed, and so now you can get that lateral wall in, which we couldn't get before. You have a nice 2-chamber view, which we did not have before. Okay? And then we actually do a quick 3D on it. If you want, I can quickly show you, because we did the one at baseline, so let's see what we got now. Anterior wall, inferior wall, apex. And then there are different things you can do. So if I do sequence analysis, it will actually do more measurements, and you can see if you agree with your tracings. It's not perfect, but I'm just going to take it.
But I guess you're saying you did see significant improvements actually the LV.
Well, it's not just a EF improvement, but see, this is showing you the synchrony. So these are the segments of the LV, and the smallest end systolic volume is the scatter would be less, compared to that. And then what you do is you go to the report page, and it's giving you 53.6% EF. And then you can do, this is all research that I have actually done with this too, and I can go over that with you later. This is actually giving you the excursion of individual segments. So here is the same LV afterwards. You can see that the contraction, at least here, is a little bit better, and that compression that you were seeing of the RV is gone. So you see that overriding of the tricuspid valve is gone, and the tricuspid annulus is wider. And this was the compression that you saw before, which was narrowing the RV. Now you can see more RV cavity here, and you can see that the LV looks better. It's not as wide, and the wall motion looks better. In fact, if you looked at the previous 4-chamber, as a cardiologist, I would have thought there is some kind of conduction abnormality.
Wow.
And now these young people I've seen, their EFs are not very brisk. They are generally in the low 50s. So for this patient, this EF is actually normal. The other thing that we look at is the hepatic vein flow, and I will show you that as well. This is so one of the things that we have noted is that because the RV is compressed, the hepatic vein flow is not, the hepatic vein or the IVC does not fill the RV as well. Okay, so this is the hepatic vein signal at baseline. So you see there is the velocity scale, it's less than 10 and it's all kind of diastolic, there's no systolic flow. Notice our angle, we try to align it as best as possible, but sometimes this is the best we get. Now, I didn't do this, the fellow did it, I might have been able to get a better alignment, but we look at this flow, the VTI of this, and in which part of cardiac cycle it is in. So just note this signal, and then the one we got after repair is this.
Wow.
You see that? So it's now over 20, and now you're getting systolic and diastolic flow. We have a better alignment. Part of that is because it's difficult to get images with the pectus deformity, but that's another thing they found is improvement in hepatic vein flow.
Wow.
And that's what leads to increased filling of the RV, increased cardiac output, increased EF, you know.
That's impressive, isn't it?
Yeah.
Amazing, yeah. It wasn't even the severest we've ever seen.
Right,
So it's amazing
right,
to see that
right.
difference. Yeah, great. Thank you very much.
Sure, you're
Thank
welcome.
you. Yeah, wonderful.
We want to measure for titanium bars when you have to order them. So we're at the base of the defect, and that's up.
And fair to say, this is an impressive patient.
It's pretty.
This is our next
pretty
patient,
good, right?
isn't it?
Yeah.
47, Haller and 12.
47. Yeah.
Impressive.
So we want to measure from outside the rib over here where they're at their widest. Now her asymmetry and being down so far makes it difficult on this one. You can see where I measured here. So it's just outside the rib right there on that line.
Yeah.
And then over here on the outside of this line. This one comes out to 26.6. I think she'll get wider, so we'll say it's 27 centimeters.
Yeah.
Right? We'll call that 27 centimeters. Then we'll go up to the next interspace. I swear I put a mark. And here's another one. Right? So we're outside the rib at the widest point laterally. And we come out to 26.4. So we'll call that one 26 because we're going to round down to 26 for measuring on our little chart of centimeters here. And then if she requires one up higher, it's where she's even a little more wonky as far as sizes go and where to measure. But she comes out to 26.1, so we'll call that one 26 as well as far as conversion from centimeters to inches. It makes it easier that way. So when we go over here to 26 centimeters, it's 10.2, around that down to 10. And then you add 2.5 inches to that. Because the bars are measured in inches. So this will be 10 inches, so she'll get a 12.5 inch bar.
Okay.
Right.
So just transverse diameter, add 2 inches.
Correct, at 2.5 inches, because that's the length that goes around the side of the patient.
For the bend. Yeah.
For the bend.
Okay. Well, that's
And then the
easy.
next one was going to be 27. The bottom bar is going to be 27 centimeters. And that's 10, we'll say 10.5 inches just for measuring. So that's a 13.
Yeah.
Right.
Okay.
So
Easy.
it's made it really simple because that way even I could do it.
Yeah. You don't have to do semicircles
No,
and measure
yeah.
diameters and
Correct,
radiuses.
yeah.
Just do that at 2.5 inches.
Yeah,
Easy.
we measured a whole bunch of patients and then kept track of what we put in patients, and that's the algorithm that we came up with.
So that's the end of the video. Thank you so much to Dr. J, Jesse, and everybody at the Mayo Clinic for making us feel so welcome. I hope you've all found this very helpful and very useful and found loads of hints and tips that you can use in your own practice.